implantation in hospital setting challenges the experience of the cardiac center. Directly. Thank you.
Good morning, everyone. I am happy again to present to you during this session on cardiopulmonary bypass implementation challenges. Like Dr. Amasa said, we are bilingual. I speak in English, but my presentation has French translations. We know that cardiopulmonary bypass is the backbone of cardiac surgery. Therefore, it is good for us to get some idea about what is happening in terms of challenges. Our outline runs from introduction, our brief experience, some challenges, and the conclusion. We know cardiopulmonary bypass, or we also call it extracorporeal circulations, means the utilization of a device or a machine to replace the functions of the heart and the lungs. That is why we simply refer to it as a heart-lung machine. We have the images. For the sake of time, I will not go elaborately to explain, but I beg that our eyes will be able to capture exactly what we are talking about. And it is always nice for me to really remember our experience from the beginning, and we always have some people to remember. And for the sake of time again, I am so honored that I have here Dr. Ambassa and Dr. Kaba coincidentally sitting on the panel here. We thanks to them at the beginning that we have a lot of hope, the dream come true, and so many people. We also have our sisters who are present with us, and we are grateful about our works at the beginning, that we call it humble beginnings, that we have the results we are able to present today. Like I said, for the sake of time, I will be very fast. And now, what is more important is that we can be happy that Shishoan Cardiac Center is able to write a history of Africa, or especially for the Sub-Saharan Africa, and we are able to apply the difficulties that are coming from here to explain the issues about cardiopulmonary bypass. And I also indicate that the statistics I shall be presenting are known for cardiopulmonary bypass, just to indicate that in surgery, not all the cases we do are done with the use of cardiopulmonary bypass. And therefore, in our results, the patient population came from Cameroon, Nigeria, Chad, Equatorial Guinea, Gabon, etc. And we have pathologies both in adults and pediatrics, ranging from various pathologies as indicated on the slides. Then we always talk about our collaboration, our networking, and it's just to explain here that our relationship, just like Dr. Amos had presented earlier in the first session, we work with European, African collaboration or experience, and also had the opportunity to work with some African countries like Mozambique, South Africa, and so on, to be able to establish the results that we have. It is also good to summarize exactly our train of activities, to say that we had a period of 2002 to 2008 where we have formation abroad for the personnel we had. We quickly went to this particular moment, the exciting moment where we had the inauguration. After that, we had this period from 2010 to 2014. We had this exchange with local missions. And then we went to a period where we get autonomy from local team. We are able to work on our own. We have this period that is very painful. Remember the period of the socio-political crisis where everything to see to a standstill. And where we are now from the period of 2019, we have the idea of what we describe as a rescue mission, where we had worked in collaboration or through the assistance of some hospitals like when we work in the Jordan Hospital, Yaoundé, and the General Yaoundé. Then briefly, or just in one slide, if you look at our activity, you'll be able to see from here the fluctuations. This period while we are in Chisom, how our activity roll on. This is again about the cases we deal with the help of extracorporeal circulation, excluding all ours we did, and then we have the period where the evidence seems to stand still. Then we have this other period where we were in Yaoundé and trying to maintain the rescue mission activities. Then, after those brief results, the most important question we are answering in this presentation today is what challenges characterize our experience? And the key challenges that we summarize in 7 points. The first one is the difficulty in the performance of complex cases. There are difficult cases to perform that makes more than does what we describe as the traditional CPP or traditional extracorporeal circulation. And the second challenge that really came is the purchase of different consumables. You can get an idea about what I'm talking about from the pictures that are being projected. And then we also have the same challenges which are about what we call the hardware materials. We know that materials or equipment for ECC are both the disposable and the hardware. Sometimes to get the hardware or to get the proper machines costs a lot of money and maintenance, and that has been one of the challenges too. And then the central thing about extracorporeal circulation or cardiopulmonary bypass is what we call myocardial protection, which is explained in 4 stages: arrest with potassium, hypothermia, myocardial edema, and buffering acidosis. This has been also a difficulty in terms of when it comes to pediatric, the immature nature of the child, and then the option of choosing between what we call crystalloid and blood cardioplegia has been also a great challenge. And the next thing was, in Cameroon, and especially in most of Africa, we don't have personnel the training for this kind of session. It's really difficult, and we have what we call on-the-job training, and that's why the number of personnel we have becomes a problem. The practice of special procedures apart from the traditional bypass is also a problem, just like the formal education we do is also another challenge that characterizes our experience. And it is not only ending there. One of the difficulties in the intensive care, the work we do in ECC manifests in the intensive care, and therefore the challenges in being able to arrest or prevent complications at the level of intensive care was another one. And we have other issues which are general problems, like the kind of cases that we can handle. You are putting a patient in cardiopulmonary bypass, but you are not sure that what we call the moribund cases, will they be able to get out easily because of the late stage of the disease, and then the difficult in getting blood, because we cannot do this session without blood. And quickly, because of the sake of time, my rapid talking and presentation has to summarize one thing. Sometimes when you present from the point of view of challenges, it is tempting to say, is this possible, can we make it? But there is always a goal set that it is always impossible to do it if you don't begin. So if you don't begin, or if you don't start, it will never be possible. And how can we succeed, therefore? The main thing is what we are looking for the future. We need collaboration, we need a board, we need integration into our university curriculum, and we need to do a lot of research and exchange, thanks to also the Cameroon Cardiac Society, that we are able to share briefly this experience. Thanks very much for your fervent attention. Thank you.
Thank you, Mr. Franck Marcel. We are honored to have you in our midst, because I know what is your value in terms of extracorporeal circulation. This is somebody, when he is sick, there is no surgery. The surgery does not work. So if you want to delay the surgery, say I have fever. Yeah. We are going to receive some few questions, 5 minutes, and we conclude the session. If we can have some questions about the three presentations that we have in this session. Thank you. You give the microphone there. You introduce yourself and then you give us the question.
I am called Dr. Rebecca Nina. Dr. Rebecca Nina. I'm an internist practicing at Bingo Mbopi. So I have a series of questions. First, directed to Sister Doctor. Okay. In your presentation, you were presenting the sudden death. I think in your first causes of death, I didn't get anything maybe like myocardial infarction. And I want to assume that a center like yours, that maybe when patients come in, you quickly get maybe an ECG compared to getting a CT scan. Because for most of the causes, we have more of a cerebrovascular accident. And I want to consider our setting where maybe the patient should not have the money ready to do a CT scan. And so how quick are you able to get a CT scan say in less than 3 hours, in less than 9 hours? And yeah, I think those were the questions for sister. So nothing about maybe reading abnormalities as to your etiologies or something.
We can give the microphone to Sister Dr. Lennon, please.
Thank you very much, Doctor. I think from our presentation, we presented clinical because, first of all, there's no scanning machines in Kumbu. We must transport people to Bamenda or to Bingo Hospital in Kom. And those who are arriving already at the moribund state, transporting them means that we want to facilitate their dying. So all were clinical diagnoses that we posed looking at the clinical presentation, and the patients quickly passed on.
All right, thank you. It means you were able to also get an ECG. So my point was, were ECGs done, and were there not some reading abnormalities that were picked?
Thank you.